Hi all, and welcome to Professor Truelove's Concepts for Nurses series. And I am Professor Terry Truelove. And in this episode, part of the Orthopedic series, we will be looking at interventions following fractures. A dangerous complication following fracture is acute compartment syndrome. Therefore, these are the priority interventions. You should remember that within 4 to 6 hours after the onset of acute compartment syndrome, the neuromuscular damage is now irreversible. The limb can become useless within 24 to 48 hours. Therefore, monitor the compartment pressures. Loosen tight dressings or provide a bivalve restricted cast as prescribed. And you should consider the patient may have a surgical cutting into the compartment known as the fasciotomy. A cast is a rigid device that immobilizes the affected body part while allowing other body parts to move. Cast materials can include plaster, fiberglass, polyester cotton, and air casts. The type of cast varies depending on the type of body part involved. So there's different types of casts and shapes for the arms, the legs. There's different braces that sometimes can even include the entire body. For instance, some of the different types of hip. The care of plaster casts include to remind yourself that it takes about 72 hours for it to totally dry. And while it's doing that, while it's curing, it's giving out heat. It needs to be handled by using only the palms of the hands. Do not cover the cast with linen. Do skin assessments around the cast and protect it from sharp casting material, that is the skin, and instruct the patient not to stick objects inside the cast, even if it itches really badly. If damage is noted to the cast, mark it on the cast and the date and time. Also mark any drainage and outline the area of drainage and date and time, that marking as well. The patient with a fracture should initially have neurovascular checks every hour for 24 hours and then every 4 hours. Instruct the patient to report pain and pressure. Have the patient elevate the extremity to decrease edema. Remember that ice therapy is also effective in reducing inflammation and pain, and provide pain management with NSAIDs and opioids. In some cases, the pulling or traction of the limb is indicated. Traction occurs when there is exertion of a pulling force is applied to two different directions. This reduces and immobilizes the fracture. This helps to provide proper bone alignment and reduces muscle spasms. There are different types of traction, including skin, skeletal, plaster, brace, and circumferential. Skin traction is applied by using elastic bandages or adhesive, a foam boot, or a sling, and is used to decrease muscle spasms. There can be cervical skin traction, bucks or extension traction, Russell skin, that is sling traction, pelvic skin traction, balanced suspension traction, or Dunlop's tractions, all of which are types of skin traction. Commonly, currently, bucks or extension traction is the most popular. Skin traction care includes remembering the patient should remain in a low Fowler's position on either side or the back. You should maintain a 20-degree angle from the thigh to the bed. Maintain a correct balance between traction pull and countertraction or the countertraction force. Make sure the weights are free and not hung up on anything. Frequently inspect the skin for friction burn or injury, and do frequent neurovascular checks. Skeletal traction is accomplished mechanically with the use of pins, wires, or tongs directly attached to the bones. This does aid in bone realignment. The typical weight for skeletal traction is about 15 to 30 pounds, and this is in contrast to the 5 to 10 pounds used in skin traction. An example can be used in cervical tongs or a halo fixation device, both of which for cervical spinal fractures. Monitor the patient in skeletal traction for neurovascular status. Look at the insertion sites for redness, swelling, drainage, or increased pain. Frequently inspect other areas adjacent to the insertion sites. Provide for pin care depending on the policy and procedures of the facility, and monitor the weights Make sure they are freely swinging and not impinged upon anything. If you suspect fat embolism, you should know that there is no specific treatment for fat embolism. You should notify the physician and place the patient in high Fowler's position. Start him immediately on oxygen. Monitor vital signs and respiratory status. You may have to prepare for intubation and possible mechanical ventilation. Make sure you have an adequate rescue IV, a big bore, and you may know that corticosteroids may be prescribed to reduce inflammation and reduce damage to the affected organ. Drug therapy are opioids and non-opioids for pain control, anti-inflammatory agents to reduce the swelling, and muscle relaxants to reduce spasms. One type of surgical management of a fracture is called open reduction with internal fixation, or ORIF. Internal fixation involves the application of screws, plates, pins, or intramedullary rods to hold the fragments in alignment. It may involve the removal of damaged bone and replacement with a prosthesis or bone graft. It provides immediate bone strength and immediate bone stabilization. An external fixation is the use of an external frame to stabilize the fracture by attaching skeletal pins through the bone fragments to a rigid external support. This provides more freedom of movement than with traction. You should monitor pin stability and provide pin care to decrease the risk of infection. It's commonly used when there is massive tissue trauma present. Postoperative care for an ORIF is similar to any other surgery and it starts with ABCs, but complications specific to fractures in musculoskeletal surgery include fat embolism syndrome, venous thromboembolism, and infection, so the nurse would be prudent to monitor for those specific complications. The recovery period includes pain management, usually through the use of patient-controlled analgesia. Teach the patient to ask for pain medication early, before the pain becomes too severe. You should prevent the subluxation or dislocation, particularly after total hip replacement, using an abduction pillow, to remind the patient not to flex the hip past 90 degrees, to use an elevated toilet seat, and teach the patient not to cross their legs. But of course also include frequent neurovascular checks, hydration and nutrition, turning, coughing, and deep breathing, monitoring of the incision site. Remember to encourage the patient to flex and extend the feet to reduce the risk of deep vein thrombosis. And physical therapy should be instituted postoperatively with progressive ambulation. To prevent DVT and PE, use compression devices, start the patient on anticoagulant therapy, and make sure that you remember that there will be drains, including hemovacs, which you should make sure are patent and secure. With close reduction, the provider manipulates the bone back into alignment without surgery. So immobilization will therefore be done with a bandage, a splint, cast, or even traction. If this occurs, this requires frequent neurovascular checks, a cold pack for the first 24 to 48 hours, to elevate the extremity higher than the level of the heart, to provide for fluid replacement, particularly if there is blood loss. And this close reduction is indicated for the more simple fractures. That does conclude this episode. I hope you learned a little bit in this episode, and I hope you plan on coming back and listening for more. And if you are, we'll see you then. Take care.